Smoking causes fatal diseases and cancers to develop in many parts of the body, including upper and lower respiratory tract, the esophagus, and kidneys. We'll be talking about quite a few of these diseases later on. Because Bob has been smoking for 30 years now, it will have impacted him somehow. Brannon, Feist, and Updegraff 2017 have pointed out that when tobacco is burnt in a cigarette, the smoker is exposed to over 4,000 chemicals. They have also pointed out that these chemicals cause damage throughout the respiratory tree, from the main airways, the bronchi, to the peripheral airways, the bronchioles, right down to the terminal alveoli, also known as the air pockets, as well as to the immune system. Loss of cilia and mucus gland hypertrophy occur in the upper airways. Inflammation, epithelial changes, fibrosis, and secretory congestion occur in the peripheral airways, and alveoli are destroyed with loss of gas exchange, all having a negative impact on the way the lungs work. Smoking also impacts brain matter. So COPE 2016 has explained smokers may experience improved memory and enhanced fine motor skills in the short term, but in the long run, they have more problems with working memory, problem solving, and general intelligence. This is because smoking causes more pronounced brain atrophy with advancing age compared to people who have never smoked. This means the brain shrinks faster, with particular decline in the cognitive or problem-solving grey matter, as smoking restricts the blood flow to the grey matter, thus reducing its processing power. The general appearance of a person is also affected by smoking. Smokers tend to age at a faster rate than people who do not smoke. It can often lead to early wrinkles, sagging of the skin, grey complexion, loss of natural glow, yellow teeth, dull and less vibrant skin, hair, and nails. Chrysanthi 2016 has explained that several studies indicate that in nicotine, the cigarettes cause vasoconstriction, which narrows lumen of capillaries and arterioles in the superficial layers of the skin. This in turn results in a decreased blood flow and reduced supply of nutrients and oxygen in the tissues of the skin. They have also stated that tobacco smoke damages the tissues through chemical interactions. It contains more than 4,000 chemicals which contribute to the degradation of collagen and elastin, which are connective tissue fibers in the skin that give it its strength and elasticity, which results in the skin sagging and wrinkling. A medication that could possibly use to help smoking cessation is varenicline, also known as Champix. Varenicline is a drug that is used in nicotine dependence. It's indicated for people who are trying to stop smoking over the age of 18 years. It is not recommended for people who have any kind of allergy to any of the ingredients. There are precautions. Physiological changes resulting from smoking cessation with or without treatment with Champix may alter pharmacokinetics or pharmacodynamics of some drugs, such as warfarin and insulin, for which dosage adjustment may be needed. There are also psychiatric symptoms that have been noted for people being treated with Champix, such as depressed mood or development of suicidal ideation or behaviour. Symptoms such as this need to be contacted with a doctor as soon as possible. Based on varenicline characteristics and clinical experience to date, varenicline has no known clinical meaningful drug interactions. However, smoking cessation itself may result in changes to the pharmacokinetics of the drug. There are adverse reactions. Smoking cessation with or without treatment is associated with various symptoms such as depression, insomnia, weight gain, and difficulty concentrating. The dosage recommended for Champix is 1 milligram, which is 1 tablet, twice daily after eating. Your doctor will probably start you on a lower dose of varenicline, which will gradually increase over the first week of treatment. A nursing intervention that could be put into place to help Bob with his smoking is by Wes in 2010, known as the 5 R's model, where the first R is relevance, encouraging Bob to indicate why quitting is personally relevant. Risks, identify potential negative consequences of tobacco use. Rewards, identify potential benefits of smoking tobacco, such as improved health, saving money, and better taste of food. Roadblocks, have Bob identify barriers to quitting and help him problem solve. And repetition, repeat these steps.
Physiology for chronic bronchitis. According to Merriam and Home 2014, bronchial arteries in the lungs provide oxygenated systemic blood to the lung tissue. They provide oxygenated blood to all lung tissues except the alveoli. Also, chronic bronchitis severely impairs the lungs as inhaled irritants leads to excessive mucus production and lower respiratory passageway becomes inflamed and fibrosed. According to Kim and Kriner, 2012, mucus metaplasia is the main cause, which is the overproduction of mucus due to inflammatory signals. This is due to the hypersecretion of goblet cells and decreased elimination of the accumulating mucus. This hypersecretion is highly linked with smoking. This will then result in poor ciliary function, distal airway occlusion, and respiratory muscle weakness. This is exactly what has happened to Bob. Not only did he work in a factory with chemical fumes, he has also been a smoker for most of his life. This would result in mucus pooling and could lead to various types of infections. Pathophysiology for asthma. Asthma is characterized by a recurrent episode of airway obstruction, which reverses either spontaneously or after use of medication, and is usually associated with bronchial hyperresponsiveness and evidence of chronic airway inflammation. Martinez and Vercelli, 2013. Since Mr. Moore has had asthma for most of his life, he has been using his Ventolin inhaler to help deal with the bronchial obstruction. Due to his smoking, he has made the situation worse. Asthma happens when the bronchial linings overreact to various stimuli, which causes smooth muscle spasms and restricting the airflow. This is due to IgE antibodies attached to histamine mast cells and receptors on cell membranes to initiate the intrinsic asthma attacks. Furthermore, histamine will stimulate mucous membranes to generate more mucus, which will cause the lumen to further narrow. Kirk, O'Shea, and Ruff, 2010. This would result in Bob feeling that he's unable to breathe and struggling for air. Pharmacology for chronic bronchitis and asthma would be the use of Ventolin, as it is used to treat and prevent bronchospasms, which may also help reduce the effects of chronic bronchitis. They are adrenergic bronchodilators, which means the medications are breathed through the mouth to open up the bronchial tubes in the lungs, and this is done by the beta-2 agonist, which stimulates beta-2 receptors on airway smooth muscles and mast cells. It does this by the beta-2 agonists, which stimulate beta-2 receptors on airway smooth muscles and mast cells, resulting in bronchodilation and inhibition of mast cells mediator release. The onset of short-acting beta-2 agonists is approximately 5 to 15 minutes, and the effects could last for up to 4 to 6 hours. It can be used as an inhaler, nebulizer, pill, and an IV solution. Albuterol can relieve symptoms like cough, wheezing, shortness of breath, and trouble with breathing. Drug interactions could be amipetine, doximine, and opiopromol.
Okay.
Recommended dosage would be a metered dose inhaler, 2 puffs for every 4 to 6 hours. More frequent administration or large doses is not recommended. Precautions: excessive use of short-acting beta-2 agonists may lead to a non-responsive state. If Bob is starting to rely too heavily on his Ventolin pump, then it may mean that his condition is worsening and that his therapy should be assessed. Adverse events could be hypokalemia, which is more likely to be a result with the frequent use of corticosteroids, theophylline, diuretics, and patients with hypoxia.
Okay.
Side effects could be bronchospasms, chest pain, and fast pounding or uneven heartbeats, according to MIMS Online. Nursing management for bronchitis and asthma. Mr. Moore is an elderly gentleman who has come into hospital with complications due to COPD. We as nurses must be aware of the patient's past health history to be able to look at the bigger picture and help treat the patient accordingly.
Okay.
According to Forbes and Watt, 2011, the main objective for obtaining a health history is to get subjective data from the patient and compare it with the objective data from the physical assessment. It is also very important to ask the patients about their perception of their health and how they view their condition. Another important nursing management would be auscultation. Auscultation is a process of listening to sounds that the body produces using a stethoscope. Cooper and Gosnell, 2014. In this case, we would want to focus our area towards the respiratory division. The nurses must continue to auscultate Bob Moore to identify the type of sound and region from which it is emanating from.
Okay.
The crackling sound suggests that there is a buildup of sputum in the trachea and the bronchi. These are short popping sounds which are described by their pitch, timing, and location. This cracking sounds commonly occur in patients with chronic bronchitis. Bass and Thompson, 2010. It will be important for the nurses to be able to frequently examine Bob's lung sounds to ensure that their intervention, such as medication, is helping him and possibly reducing the amount of crackling emanating from his chest.
The pathophysiology of COPD is classified as a progressive lung disease that includes emphysema, chronic bronchitis, and chronic asthma. Lung Foundation 2016.
COPD is commonly attributed by the history of tobacco smoking, Herb 2012. Smoking acts on mucus-secreting glands of the airways, and often patients with COPD have excessive mucus secretion, leading to chronic coughing. Goals, Krisiak, Prescott, and Australian Institute of Health and Welfare 2010.
Other contributing factors that can lead to COPD could be in the form of childhood asthma or childhood respiratory infections. Lung Foundation 2016.
Respiratory conditions as such, along with age-related changes such as decreased gas exchange as well as increased respiratory effort, requires attentive nursing management. Dempsey, Hillage and Hill 2015. COPD is a serious and progressive disease associated with shortness of breath and coughing irregularly. A major contributor for the development of COPD is trauma, narrowing and constriction of airways, as well as destruction of alveoli caused by emphysema.
A patient with COPD suffer from symptoms that include shortness of breath. So this can affect an individual person's life, especially in terms of fitness. So as COPD progresses, so does the shortness of breath. The longer it progresses, the more it affects the person's life. It can affect them up to where they struggle to do daily tasks, such as getting dressed. Other symptoms include a continuous cough with phlegm and mucus, a history of smoking, and exposure to environmental pollutants. The symptoms that come from COPD can affect a person's sleeping pattern, ability to participate in physical activities, and quality of life. It impacts a person's quality of life due to suffering from depression and anxiety.
Disability from COPD is most common in males, which makes us more and more susceptible to damage. According to Gold, Krisiak, Prescott and Australian Institute of Health Welfare 2010.
Underlying conditions of COPD that patients suffer from include diabetes, lung cancer and depression. Lung Foundation 2016. There are 4 stages of chronic obstruction pulmonary disorder.
Stage 1 is characterized by mild airflow limitation, chronic cough and sputum production, forced expiratory volume, forced vital capacity of 80% or higher, increased mucus production, wheezing and fatigue, according to Williard 2012. Stage 2, airflow limitation deteriorates even further. Symptoms progress with shortness of breath, particularly on exertion, FEV1 and FCW of 50 to 79%, and severity of cough worsens and becomes persistent. Williard 2012.
Stage 3 is severe, so FEV1 is between 30 to 50% predicted on airflow obstruction. Stage 4 is very severe, FEV1 is less than 30% of airflow obstruction. So patients who reach stage 3 and 4 have poor pulmonary function. They have a faster decline within the disease in comparison to those patients who are at an earlier stage. For those patients who reach stage 4, they need to consider surgical options such as lung transplants and lung volume reduction. Within all 4 stages of COPD, respiratory rehabilitation should be considered. This would benefit those patients who have muscle weakness and poor quality of life. The treatment is aimed at improving their quality of life and being able to exercise and do everyday activities. Deucrama, Insians, and Miravitilus 2012. So a drug that could help Bob with his COPD could be Symbicort. So Symbicort is an inhaler that is used on patients with moderate to severe COPD. It helps with the treatment of airflow obstruction in patients. To help aid with easing symptoms, Symbicort contains budesonide and formoterol, which both help in reducing the effects of COPD. Budesonide is a steroid that reduces inflammation. Formoterol is a bronchodilator that relaxes the bronchial smooth muscles to improve breathing. Hitchens, Lonsdale, Burrage, and Baker 2014, as well as Mims Online 2016. The adverse reactions could include headache, sore throat, coughing. Contraindications, so it's a hypersensitivity to budesonide with fumarole or any other ingredient in the formula. Precautions: if there is a sudden or deteriorating condition in the patient, there needs to be a medical assessment done. If there is a bacterial infection occurs, antibiotics need to be given. For interactions, pharmacodynamics, neither budesonide or formoterol interact with any other medication to treat asthma or COPD. With the dose, it needs to be twice daily, so a max of 4 inhalations. Mims Online.
So for common infections, drugs such as amoxicillin can be given. It's used for infections due to susceptible organisms. Contraindications include beta-lactam hypersensitivity history. Precautions for prolonged use include monitoring renal, hepatic, and homeopoietic function. High dose should, if at high dose, ensure adequate hydration and urine output. Adverse reactions include GI upset, crystalluria, and rare would include hepatitis, joint convulsion, severe skin reaction, and it can interact with oral anticoagulants such as warfarin or allopurinol. And nursing interventions for Mr. Moore would include, so the levels of activity and personal habits can change dramatically due to decreased ability of the lungs. Systemic consequences such as skeletal muscle dysfunction as well as uncontrolled weight loss can also affect the quality of activities in daily life. Vase et al. 2012. Decreased compliance of the respiratory system as well as restrictive lung function, increased airway resistance, and increased work of breathing is also associated with declining activities of daily life. This results in dyspnea and restrictions in carrying out activities that are physical. Physical exercises are reduced considerably among those that have COPD due to the increase in respiratory effort while breathing. This can therefore contribute to excess weight gain as normal day physical activities are reduced significantly. Activities of daily life involving simple tasks will then require lots of energy and effort. Therefore, higher degree activities can result in increased fatigue and dyspnea, which can contribute to a decreased quality of life. Vase et al. 2012. It is vital to increase healthy lifestyle choices in order to optimize lung function as much as possible. Dietitians that can aid in healthy food choices, weight loss programs, or exercise programs that are suitable for the patient's capacity can be encouraged in order to improve lung function. Vase et al. 2012.
Another nursing management is the education for Bob. So for Bob to start to recuperate, nurses need to educate him in self-care and self-management strategies. The main goal is for Bob to become involved in the management strategies and to accept that he has COPD. Self-care teaches Bob that he needs to look after himself. He needs to change certain behaviours such as smoking and to provide emotional support for him. Self-management is also important when educating the patient on their drugs. Nurses have the role of teaching Bob how to manage his medications, when to take his medication, and what each of the medications do. This also includes having a strategy of what to do when warning signs appear. Bruce et al. 2014. Ways to help improve his condition and his quality of life include setting goals, problem solving when a problem arises, and taking charge when decisions need to be made. Goals help achieve things which can give Bob hope and happiness in life rather than depression and anxiety that patients feel. For goals to be achieved, Bob will need to fully understand his conditions. To help Bob his condition, the tools that are available, and to use those tools when symptoms arise or worsen. Ways to help Bob manage his condition and to educate him will be in contact with nurses who can provide him with knowledge and self-management strategies. Effing, Pellin and Frith, 2014. Education is a continuous process that does not only involve nurses, but as caregivers and family as well. The educational programs that he might need to undertake would be basic anatomy, symptoms of COPD, risk factors and how to minimize them, warning signs, treating the warning signs, and having a plan and knowledge of community resources. RUS ETAL 2014. Overall, not only does educating Bob on his condition improve his quality of life, but it also helps with his symptoms of COPD. Bob will be participating in inhalation techniques, monitoring respiratory and emotional status. Through self-management and self-care, over the long run, it helps with behavioural changes and lessens the severity of his symptoms. Stephenson, Tennant, and Chaney.
So according to NSQHS, Standard 3, Preventing and Controlling Healthcare-Associated Infections, I am to perform hand hygiene before coming into contact with my patient. Hi, I'm Tina, and I'll be your nurse for today. What's your name?
My name's Bob Moore.
So, Standard 5 is patient ID, and I have to make sure that I've got all the right details before giving the medication. So, check the name, the date of birth, and the UR number. So, when you administer this medication, you will shake it and then take 2 puffs. After each puff, breathe in.
Okay, thank you.
Okay, that's it.
I'm going to give you a clinical handover. So to identify, he's Bob Moore, 60 years old, situation, he's got COPD, chronic bronchitis, asthma and chest pains. Background, he's a smoker of 30 years, worked in a factory with chemical fumes, wife died 2 months ago. Hospitalised before due to severe chest pains. Assessments, so we administered Symbicort, amoxicillin, Champix and Ventolin. The request is to monitor chest pains, odds, fluid on the lungs, his overall condition, and hourly auscultations.